So we have about 15 minutes, and I would be happy to recognize people to ask questions or make comments, but just keep it short and say who your question is addressed to, if you would. We have a microphone or two in the room, and if you would wait for the microphone to arrive, that would help our recording. People are stunned. Yes, back in the back.
Yes. This month, a study was published in the Archives of Internal Medicine that found per capita Medicare spending on the elderly has grown nearly 3 times faster in the United States than in Canada since 1980. And it also found that had U.S. Medicare spending per elderly enrollee increased as slowly as in Canada, we would have saved $2 trillion over the last 20 years, which is about 1/6 of the U.S. national debt. So the question I have is, why do you think a Canadian-style single-payer system was off the table, and why, for example, have you not mentioned it or addressed it here?
It's not off the table. There's been quite a bit of discussion on ways that we could have a more efficient insurance system. And as you remember, in the Affordable Care Act, there were many efforts to have a public option there. We did not include it in our plan because it's not politically realistic in the short term, and it's not a way to save money in the short term. But you are correct in the sense that other countries have shown that they can produce a lot better health care with fewer dollars than we have. I'm not sure that's all because it's single payer. They also have different delivery systems. They have different pricing systems. There's a lot behind those figures. But our proposal here is designed to be politically pragmatic in the context of what the Congress is going to be dealing with in the next few months. So the larger questions about the role of government, whether we should move towards a greater reliance on public sector or not, I think would be issues that would come up later.
Just as a follow-up, would you support ideally, would you support a single-payer system as a way to control costs?
You mean if I was czar? I'm not going to answer that, thanks.
You know, one thing I think, John, that would be good to just comment on, and that is for 80% or more of Medicare patients, they're in a single payer. Medicare is a single payer as currently construed today. So we're dealing with, I mean, to talk about a single payer was to take Medicare and spread it across the entire population. So the Medicare comparison of cost increases have a lot to do with demographics and other things about the systems that are different in Canada and the U.S., not about a single payer.
Well, we've got plenty of time, and I think there's plenty of detail in front of you, so I'm sure there's something that's going to provoke someone. Yes, right, Diane?
Well, this is just, I mean, one of the most immediate concerns is the SGR Fix. So how do you see it happening that, you know, Congress would act fast enough on some of the things you're proposing to come up with money to pay for an SGR Fix?
They're not going to act fast enough. The SGR is going to be delayed, as it has been many, many times before. Our hope is that SGR becomes part of a broader set of legislative changes where we transition away from SGR to a new way of paying doctors. And the legislation that's been introduced in the House by Allison Schwartz, it's bipartisan, I think kind of indicates a feasible way of doing that. So that's the kind of change that we would support. Over here.
Hi, several of you have mentioned the idea of using clinicians other than physicians at the top of their education and training. And I work on nursing issues related to that through AARP with Deb. And so I just wanted to see, Jack, you had mentioned that you've been talking to physicians about needing to change some behaviors around that, and there's definitely organized opposition to clinicians, nurses, such as nurses and pharmacists working to the top of their license. And I wanted to know, is there any hope that organized medicine would come around on that?
Well, I mean, let me just say, first of all, that organized medicine is an oxymoron. But I would say that yeah, the best of the delivery system changes already have doctors and nurses and others working together, everybody at the top of their license, and more likely these folks are encouraging increased scope of practice for everybody along the way. The idea is not to waste that intellectual talent that's out there. And in fact, having these scope of war battles is just a distraction, and it pulls us away from really solving problems. So I think that the enlightened are already working on models where, in fact, I see in cardiology practice, definitely is now built around having partnerships between nurse practitioners, PAs, cardiologists, social workers, and PharmDs. They have to work together to get the job done.
Let me go to Shannon first, behind you, and then Peter.
Hi, I'm Shannon Brownlee, Acting Director of Health Policy at the New America Foundation. So I'm interested in your suggestions for malpractice reform. And in not talking about caps, I'm assuming that you're saying these don't work,
Right.
and let's move on. So I'm correct on that.
You are correct.
In the safe harbor area, is this embedded in what you're saying, or was this not considered that physicians who engage in shared decision making and ensure that their patients are really well informed about elective procedures, should those physicians get a little bit of extra protection from failure to inform lawsuits? This has been tried in Washington State. There's a little bit of extra protection for physicians, and there's right now, it looks like there's increasing interest in using shared decision-making in the state, and other states are considering that as well.
The answer is yes, but and that is one of our recommendations, but it's not going to solve the major part of the problem. The two other recommendations that we put forward that have been tried, I think, in more limited scope, one is called disclose an offer, where there has been patient injury due to an error. The hospital or the physician meets with the patient's family, and says, look, we screwed up, and makes a settlement offer. And where that's been tried, it's been very successful in keeping disputes out of court. And part of the reason is that it promotes real communication between the patient and the physician or the hospital in a way that elevates understanding and elevates the ability to be compassionate, to forgive. And I think that we oftentimes lose sight of that. The other idea that we've looked at and like a lot is the idea of health courts. And health courts are a state issue by and large, but we think we could implement that at the federal level through the federal claims court system. And for disputes around malpractice that take place under federal programs, we could have a specialized way of dispute resolution under the federal claims court that I think could show the way toward a more rational, more speedy, and more fair system of patient compensation.
So can I ask a quick follow-up? Is there evidence from these various pilots or actual projects using these various methods, is there evidence that it actually reduces defensive medicine, the overuse of things out of defensiveness, or is it simply that it reduces lawsuits?
Yeah, that is the question, and it's a question that CBO asks. It's very hard to measure that. However, talking with people, to the extent that people's impressions are valid, the answer is yes, it does reduce defensive medicine, but it's very hard to measure. Yeah. Peter?
The 7 strategies that you've adopted, and by the way, I'm Peter Thomas from the Consortium for Citizens with Disabilities. The 7 strategies that you adopted appear, at least to me, to be completely sound. There's so many provisions that are out there and proposals that could fit under those different strategies. So as in conversations with you and your staff and in reading the report and picking up kind of in between the lines, it struck me that you really did go overboard to try to figure out ways to to put forward proposals that didn't negatively impact patients or compromise access or quality or choice, at least from our reading. And there are some provisions where that is debatable. I'm sure some folks would disagree with that on some particular provisions. But can you explain how your policy committee and board settled on some of these specific proposals as you went through this process of developing the paper?
Well, briefly, we do have a policy committee that's open to participation by all members. Generally, it's been meeting once or twice a month. Each meeting is focused on a particular area, and through that process, we bring in outside speakers and experts, and through that process, we've developed this set of recommendations. So it's been almost a year-long effort to focus on ideas that work, looking for examples that we can incorporate, and running them through our membership, really. Before then, it finally went to the board of directors for final decision. Over on this side of the room, just a few more minutes left.
I'm Sally Greenberg. I'm executive director of the National Consumers League, and first I just want to weigh in briefly on the whole issue of medical malpractice, which is I've always found it hard as a consumer advocate to distinguish between defensive medicine and, in a fee-for-service based system, adding on various procedures which a doctor can then be compensated for. So I think there's it's a very gray line, and sometimes defensive medicine is just taking good care of people. So and consumer organizations as a whole look askance on the whole health court construct, because it could add a lot of money and create a whole new bureaucracy for dealing with these claims that come forward. John, I would agree with you on the issue of the medical malpractice system being broken. I'm not sure it serves patients. It's very hard to get access to a lawyer to bring a case. So there's some really good ideas in this report, but some that I think need to be rethought about a little more carefully. But I wanted to ask you something before. You talked a bit about medication adherence. And I noticed that you've got a couple of recommendations in here. Do you see the costs of the current system in which Medicare is now rewarding those hospitals that do better when it comes to readmissions? Do you see actual savings there? Do we have any good data for how the system is working? The hospitals that have the highest rates of readmission get, it's a carrot and stick approach. They get slapped a bit, and those that have better readmission rates, lower readmission rates, are rewarded. How do we see that working? And maybe you can address one or both of my questions. Thank you.
We recommend the expansion of that approach to a wider range of reasons for readmission, for avoidable readmission, preventable readmission, and we urge a higher rate of penalty, because I think that what we're really trying to achieve here is greater integration between inpatient and follow-up care, and patient medication adherence is part of that, not the only part, but part of it. Today, about 20% of prescriptions are never filled. For people with chronic conditions, after about 6 months, about half are no longer taking their medications. So this leads to a lot of unnecessary care. It's not all post-discharge, much of it's outpatient, but there's a real opportunity there to save money and improve care at the same time. Maybe one last question? Yes, right here.
Hi, this is Sherry Erickson with the American College of Physicians, and I was curious. I am very impressed with the set of policy recommendations you all have in here, and they're very much in line with a lot of our policies as well. I'm curious what your next steps are and where you plan to go with these going forward.
Well, this is designed to be a package that offers suggestions to policymakers, and we want to bring this to the attention of leaders in the House and the Senate and in the White House. But we also want to do what we can to bring the health community together on the same page about the direction that we need to go forward. And so that means all of us in the room. It means all of the members of the National Coalition, and it means others. We want the dialogue, and hopefully we can move forward then, not just in generalities, but to specific action steps that Congress can take, that state governments can take, that we can take in the private sector to improve the value of health care. We've got many, many examples that that's already underway. We want to accelerate it and broaden it because the urgency is upon us now. So we're hoping that this can be a catalyst to that kind of effort, and we welcome ideas and continuing dialogue with those of you here today or those of you watching later. So thank you very much for coming. And we have a website, and please feel free to refer to that too. We'll give you a chance to